Again, hello and welcome to our Tuesday webinar. This time we'll be comparing analog and digital prosthetic workflow for SIC invent implants. And with this topic, we couldn't think about better expert than our today's speaker, Dr. Alexander Simonenko from St. Petersburg, Russia. Dr. Simonenko is an implantologist, Shili Implantology Circle member, and a CEREC trainer. But I will let him introduce himself in a while. Before that, I just want to tell you that last week I watched this webinar in Russian language. The webinar was organized by our Russian partner, STI Dent. And since the topic we will be covering today is pretty complex, I would like to, without further delay, to hand over to Dr. Simonenko. However, before that, short housekeeping. As always, we will mute everybody, but we ask you kindly to send your questions via chat on Zoom, and for those watching us on Facebook, to ask questions in the comment sections. And we will answer the questions at the end of the presentation. So now, Sasha, the show is all yours.
Thank you, Wojtek. Thank you, Niklas. I'm glad to be here again. This is my second presentation for SIC company. And ladies and gentlemen, I'll be appreciate all of you ask the questions at the end of my presentation. I'll do my best to answer your questions, so don't be afraid. Where's my mouse? Second. Okay, let's start. Okay, the topic of our discussion is a comparison of analog and digital prosthetic workflow. Some words about me. My name is Alexander Simonenko. I'm a surgeon, implantologist, prosthodontist. I'm from Russia. At the moment, I'm a SIC opinion leader, Shili Implantology Circle member, and certified CEREC trainer. This is St. Petersburg before coronavirus, and nowadays St. Petersburg is absolutely empty of the people. This is the main street of St. Petersburg Nevsky Prospect, and look at the prospect right now. There are few people only, unfortunately. But we are still strong, and St. Petersburg are still the most beautiful city in Russia. Just look at this. Okay, there are a lot of types of prostheses on implants. We can divide them on removable and fixed prostheses. By the type of production, we can divide them onto analog and digital prostheses. When we get prostheses from lab, we call them laboratory made, and by the way, we can make them by ourselves in clinic. This is chair-side type of prosthesis. And of course, we can understand that we can fix prosthesis by cement, or we can retain prosthesis by screw. And when we need to decide what type of prosthesis to choose, screw retained or cemented, we need to understand 2 points. The first point, screw hole cannot be on the buckle, the top of the buckle cusp, because the filling, composite filling on the top will be destroyed with chewing force, and this is unpredictable. And the second point, we can't position in this hole on the buccal surface because this is visual zone, this is aesthetic zone, and we will get a compromised restoration in that way. There are a lot of types of the connections. We understand that there are hexa and octagons, for example, SIC or Zimmer. There are tube-in-tube connection, for example, Nobel company. There are conical connection without positioning index and Kelos Bicon. It's very difficult in handling. And there are conical connection with positioning index. I really like SIC Vantage connection because it's incredible. And I think the future is behind that connection type because we have a maximum physical stability and we don't have to solve problems with position of our abutment because we have positioning index. There are some causes of bone loss due loading, and we cannot recognize direct we can recognize direct mount between screw type of connection and bone loss. And there is a great investigation, implant abutment GERB versus microbial colonization. It was made in 2013. And after that investigation, we can understand that the main reason of bone loss is not the type of connection, but the depth of the connection. Because of that, I really like Vantage type, conical type of SIC because it's very deep. And of course, we need to understand peri-implant anatomy because around the implant, there are not so much connective tissue like around natural teeth. And of course, we need to understand biological width because when we make prosthesis on implant, we need to get biological width 3.8 millimeters. If that level will be less than 3.8 millimeters, we will get bone remodulation and some gingival recession in the future. First type of production is analog flow. This patient is very old case of mine. This patient lost 2 teeth and came to us, but we install implants one after each other because the first tooth which a patient lost was tooth 4.6, and the second tooth after 3 months the tooth 4.5. Just look in the X-ray immediately after surgery. Of course, you can recognize some problems around the implant neck, around posterior implant, and around implant apex in the mesial region. We will come back to this X-ray in a little future. Okay, we install 2 implants. After installing 2 implants, we need to make impression, and we fix open tray impression abutment. There are transfer abutments open tray technique for hexagon platform, a lot of types. We have 4 heights for each platform. And also we have a lot of types of open tray transfer abutments for Vantage platform. The second way, we can make our impression with closed tray technique, and that way we need transfer abutment for that technique, for closed tray technique. On the screen, you can see abutments for hexagon platform and also for vantage conical platform. And pay your attention that in a conical platform, you can get very thin transfer abutment because there is 3 types of connections. And of course, we need some cap, plastic cap will be fixed on the top of our abutments. For only for vantage, for conical platform, we have very interesting option. We can use standard straight abutment, and we can use special cap which can be fixed on that abutment. And after that, we can make impression without any impression post, only use abutment and that cap. Very interesting and very cheap. And you can ask me why that implants have such converging angles. Because a patient lost the first tooth, number 4.6, and we install implants among adjacent teeth in the center of the defect. And after 3 or 4 months, patient lost the second tooth, 4.5. And of course, we install these implants directly according to natural tooth angle. And that way we got convergent angles of 2 implants, but this angle is about 10 degrees. I think it's not a problem for any prosthetic type. After making impression, we need to make gingiva mask with some type of silicone, for example, Gingifast of Zermatt. And after that, we or our technician need to make a cast model. I really like AquaTrack system from Colting company. It's great, it's very simple, and you can use it in clinic also. But these slides are from my technician. Cast model was made. And after that, we need to choose abutments. There are a lot of types of standard abutment. When we speak about analog workflow, we need, most cases, we need to use standard abutments. And they are absolutely the same for vantage and for hexagon platform. Difference is only in type of connection. And of course, we have small but very interesting option to make to get lateral fixation of our crowns with standard abutment with this small lateral screw. And of course, if you need to make individual emergency profile, you want to give patient individual approach, you can use universal cast-to abutments. They are available for single restoration or for bridged restoration without connection. We need to make abutments straight. We need to medium them by our hands to get zero angle between abutments after preparing abutments on screen. And of course, we need to get distance to antagonist for our restoration. And after that, technician need to make copies of our crowns First layer is acrylic resin. It should be burn out acrylic resin. After that, technician makes second and third layers by Modelium wax. This screen is after casting. We got metal cast crowns, metal cast coppings of our crowns. And after that, we need to close the metal. We need to use opaque layer porcelain. After that, technician use dentin and transparent layers to get aesthetic and get final shape of our restoration. Before moving these apartments to the clinic, technician needs to sandblast the surface of our apartments to clean them, checking the restorations, checking fitting the restorations. And after that, these crowns and abutments were moved to clinic, and we fix abutments first. Please do not forget to use torque wrench. Some young doctors without great experience very often forget to use torque wrench, and this can bring us to great problem in the future, because our crowns can be broken. And we need to get only 20 Newton per centimeter for SiC implants. And when we use conical connection, vantage connection, we will get cold welding, and after that we can unscrew our screw, and abutment will remain in the place, and we can chew with that crown on the abutment without screw. But you don't need to do this. You need to remain the screw on the place, but you can have this option. Crowns were fixed, and after 1 year, gingiva is okay. There is no any inflammation. Patient is happy. And let me back to the first X-ray immediately after surgery. Do you remember this X-ray? Great problems around implants. And after 5 years, we have a great level of our bone. This is comparing to the level of implant necks. There are no problems at the axis, at the apex of implants. And this is because the first X-ray, the bone around the neck of posterior implant is juvenile. It's not radiologically opaque, and there is bone, but we can see that bone. But in some years, 5 years later, the bone remineralized, and we can see the bone at the moment, and it's perfect. So don't be afraid to get such X-rays like in the left picture, because X-ray technique, it's not absolutely precise, and we can't see the bone in the place where is the bone. Don't forget this. And we have some benefits of analog workflow. The first, we have minimal investment, because we need only impression tray and impression silicone for making impression. It's pretty cheap. We have minimal requirements for manual skills. Of course, also the student immediately after university can make impression with silicon, and this impression will be okay in most cases, I think. Another method is the method of choice for big defects, because intraoral scanners they are very precise, but not such precise for big defects. In that cases, we need to make silicon impression, and after that, making digital workflow in the laboratory. And the second workflow is analog digital workflow. The patient have a lot of problems with his teeth, and there is problems for orthodontic treatment. There is a lot of indications for orthodontic treatment, but this patient absolutely disagree with us, and we need to make only one crown in the place of tooth 4.6. Drill in the bone. Using depth meter. After that, we install implant. This is a very old case also, and I used the previous type of package for implants. It's not available right now, but I like it. It's very useful, especially for front anterior upper teeth. 3 months later, we need to install gingiva shaper, small incision, and it's done. After maybe 3 or 2 or 3 weeks, we have a very good gingiva round implant. It's nice. And we need to make crown in that way. First stage, like in the previous case, we need to make impression. In that case, we used closed tray impression abutment, and also open tray impression abutment, because in that case I sent impressions to 2 different laboratories to check them, to compare them, and to solve which laboratory is better. Silicon impression on the left and cast model on the right, with individual emergency profile made by a technician. Look at this profile. And after that, we move to CAD/CAM. We move to digital part of this case. When we need to make crowns or bridges digitally, we need to use, first of all, we need to use scan post or scanning abutment. After that, we can choose what type of superstructure we can use. It can be, for example, titanium base for single crown, or titanium base for bridge work, or pre-milled abutment, or anything else. And we can use any type of software, for example, Exact or Dental Wings. It's up to you. The screen, there is the previous version of scan abutment. It's not available right now, but nowadays I use such type of scan abutment, but in previous days I used this yellow type, the previous type. This scan abutment was fixed on the model, And after scanning, after modeling, after producing, technician gives us this individual zirconium dioxide abutment fixed on titanium base. And after that, he can do crown on this abutment, but at that moment, I already have my intraoral scanner, and I used my intraoral scanner to scan this model. Because my scanner was very old, I need to use powder in that days. Scan this abutment and work with this abutment like with natural tooth. In software, I'm making the design of the crown. I check contact occlusal points, and after my design was ready, I milled this crown from Impress CAD block. After a little individualizing and glazing this crown, we are ready to fix it in patient mouth. First of all, I fixed abutment with torque wrench with 20 Newton per centimeter force. And after that, I fixed the crown onto abutment. And of course, in most cases, I design the abutment upper of gingival margin. I mean, the neck, the shoulder of abutment. Because of that, I have I'm able to fix a rubber dam with no problem. I can check the fitting of my crown to the abutment. And of course, I can remove excess of cement around the implant, around the abutment neck, to avoid any problems in the future. This crown, immediately after fixation, look at the neck. The abutment neck is upper of gingival margin. And 6 months later, miracle, we have our gingiva. Our gingiva was raised up and closed the abutment neck. So in most cases of in the posterior region, we can use the trick with abutments because the trick really helps you with handling with the crown. And in some months, you will not see any abutment margin. But I use only in the posterior region this protocol. Just look in the gingival margin. And after a couple of years, situation in patient mouth is perfect. And patient is happy because without any orthodontic treatment, without any difficult surgery, without any problems, patient got his crown. And of course, we have some benefits of analog digital workflow. First, precision of the digital producing method. It's not a secret that digital producing method is very near to analog producing method when we speak about precision. In most cases, it's more precise than analog. And we can check at any stage of production, we can check our crown, and we can fix, we can step back and remaking our crown or making design of our crown to get great precision. Of course, restoration is repeatable. We can make another restoration in just a half an hour because we have restoration file, we have digital restoration. We can get very easy mock-up or temporary crown. Before producing final crown, technician can give us temporary crown with the same shape, with no extra work. And we can check it, and after that we can say yes to our technician and get after that final crown. We can have a great visualization during treatment, also for patient, not only for us. And after that, after some evolution and maybe revolution, at the moment we have a digital workflow. We have two types of digital workflow, non-CEREC workflow, and we will see that workflow at the next presentation in 1 week, and CEREC workflow. For non-CEREC, for open system workflow, we can use, I repeat this slide, we can use scan abutment for open systems. We can use any type of superstructure, and we can use any software. It's up to you. Of course, we can scan this scan post, this scan abutment with any scanner. I'm using CEREC scanner. And CEREC is great because it's one-day dentistry technique. We can give patient his crown in 2 hours, maybe. I started my CEREC Life, my digital life, with this scanner in the middle, CEREC 3. But nowadays we have Omnicam. It's a very popular scanner all the world, and Omnicam version 2, and a new carriage with touch screen display. And of course, PrimeScan SC is the leader of intraoral scanners. It can give us very good scans. Sorry, my laptop battery. Okay, better. Very good scans. Just compare the previous Omnicam scan and PrimeScan. And we can use 3 elements of this system for getting crown. The first element is titanium base. It's available in 2 sizes, size S and size L. And SIC users must use type S. It's very important. In the middle of the screen, we can see titanium base with higher neck. And in the right part of the screen, we can see the scan post. This scan post is similar to scan post of open systems, and it uses only for scanning, not for fixing, only for scanning, like scan post in open systems. But the great benefit, What's wrong with my laptop? I don't know. 1 second. 1 second, please. Yes, good. The great benefit of CEREC system is that possibility that we can use this titanium base for scanning and for fixing our crown or our abutment simultaneously. For any open system platform, we should to use scan post or scan abutment, and after that we need to use any titanium base. For CEREC system, I repeat, we can use titanium base only for scanning and for fixing simultaneously. It's very, very important. By the way, in SIC libraries for Exacat, you can use CEREC titanium base after scanning with open system scan post. So you can use, turn back, you can use this scan abutment, scan post with any scanner. And after that, you able to choose what type of titanium base to use. Titanium base for open systems, for ExeCAD, or titanium base for CEREC. It's up to you. It's very important. The second, of course, for Vantage conical connection, you have also the same titanium bases. They're absolutely the same when we're speaking about the top of titanium base, absolutely the same. But there is a difference between connection, hexagon and conical connection. Second element of scanning is scan body, which can be fixed on the top of titanium base, and software will recognize unilateral pyramid on the top and equilateral pyramid on the top, and after that we can design our crown. Also available on size S and size L, and SIC users must use type S. And the third element is type of the blocks. Of course, I remind you about type S, you should use that type. When we use CEREC software, you need to choose Densplice Sirona Others library in this folder. And for normal platform, we need to use Camlog 3.8 library, and for white platform you need to use Camlog 4.3 library. Okay, our patients. Of course, I have a dentalist patients, but for understanding, for simplicity, I'm showing you a patient with a single or two teeth lost. Patient lost his tooth, and we can make very simple surgery. And in that case, I have used Vantage tapered implant. It's very great for soft bone. It's really great for frontal teeth, and it's available in 3.0 size. It's very useful for us because in some cases we don't have enough bone. In that case, I used 3.7 implant with length 11.5. It looks great in the package. And after fixing implant, we fix gingival healing cap with Vantage platform, with conical platform. We have great option. Do not use gingival shaper, but use this temporary abutment, which fixed into the implant, and we use it like implant inserter. And we can use this cap, this cap made of PEEK plastic, PEEK material, and we just lock it on the top of these temporary abutments. In that way, it's very useful. It's very simple. In that way, we don't need to remove. Turn back. We don't need to remove this implant inserter, and we can avoid contamination of internal part of our implant. It's very important. And after implantation, we just click this cap on the top and make surgical sutures, and we can get the same situation. Very, very simple. And 4 months later, the gingiva shape is pretty good. We don't have any information, any problems with this shape. And after that, after scanning, after designing, after producing our crown, we need to prepare in the proper way our titanium base. First stage, we need to close titanium base neck to protect it from sandblasting. I use any material, any temporary composite material, for example, liquid rubber dam material. This is my dental assistant. Because of coronavirus in St. Petersburg, we should use some suits, such suits for our treatment. So we in most cases I use sandblast. Sand is 50 microns. Titanium base after sandblasting. And of course, for a great adhesion, we need to use primer. This primer is for metal, and very, very important stage. We apply our primer on the surface. And of course, we need to use proper type of cement. Cement for fixing abutments onto titanium base should be self-curing or double curing. It's very important because light curing not good for that. Our lamp cannot polymerize through, for example, zirconium dioxide crown. So this cement should be self-double curing. It should be very highly opaque, like this multi-link hybrid abutment, H or high opaque. It's very opaque. It should be very thixotropic, and it should be very rigid for good fixation. We apply a thin layer of this cement, and after that, our crown fixed onto titanium base. And we, of course, we use polymerization lamp. I use Velo from Ultraden company. I think this lamp is incredible. It's very, very strong. After polymerization, the neck of our crown, we're ready to fix it. And of course, in that case, I use CEREC blocks, Emacs blocks. I individualize that crown a little, coloring the neck, coloring the edge. The crown is ready. I always use antibacterial material for internal part of our titanium base. Very important to avoid any bacterial infection. And the crown, after fixation in a couple of weeks, it looks great. It looks absolutely like natural teeth. And our next plan is to change this crown. It's very, very old, very old porcelain to metal crown. And some words about time logic. Sorry, I did not translate completely this sheet. This means stage in Russian, etap. So we have three types of workflow. First type, analog. The second type, the first type, analog. The second type, analog digital. And the third type, digital. We have some stages. First stage, impression, taking impression or taking scan. For analog, it takes maybe around 15 minutes. For digital, it's pretty faster. It's about 5 minutes, but I wrote 10 minutes. And for analog digital, is also 15 minutes like for analog, because we need to make the same impression like in the analog workflow. The second stage, moving our crown, moving our impression from clinic to laboratory. I wrote this sheet for the cases when our lab is behind the wall, and we just move our impression behind the wall, and after that, dental technician makes cost model. But in most cases, for example, in St. Petersburg, we can have we can have our laboratories on the other side of the city, and in that cases we need approximately 1 day for moving our impression to that laboratory. But for simple understanding, I wrote this 60 minutes for a laboratory behind the wall. For digital workflow, we don't need to move our impression to laboratory because we have scan, and we can just send our scan with email or with some services just in 1 minute. For analog digital workflow, we need also minimum 60 minutes for moving our impression to laboratory. The third stage, design. It takes approximately 30 minutes for analog workflow, because we need to make gingiva mask. We need to make coping with wax or with resin, any type of resin. And for digital and analog workflow, we need less time for making this stage. I wrote 10 and 15 minutes. And very important fourth stage, production. For analog, we need to make a lot of movement to product our crown. We need to cast it from metal. We need to apply porcelain. It takes a lot of time. So I wrote 120 minutes. For digital, milling on CEREC machine takes from 6 till 12 minutes. It's very, very fast. For analog digital workflow, we are using laboratory milling machines. And laboratory milling machines are not so fast like clinical CEREC machines. And we need approximately 30 till 45 minutes for production. Next stage, individualization. We need approximately 1 hour, 60 minutes for any type of workflow, because we need to make in coloring, and we need to glaze in our crown, polish in our crown. Is absolutely the same for any type of workflow. And second, next stage, moving our crown from lab to clinic. This stage is similar for the second stage because, of course, we need to move our crowns with courier to any clinic. And for any analog and for analog digital workflow, we need to spend from 1 hour till 1 day to move our case, our work to clinic. For digital workflow, when we use a chair-side type of production, when we have our milling machine inside the clinic, we don't need to move it at all. There is no time need. And of course, the stage of fixation, approximately 30 minutes to fix for any type of workflow. As the result, we have a lot of time for analog protocol, analog workflow. It's 375 minutes approximately. It's a huge time. For analog digital workflow, we need less time to product our crown, 275 minutes. And for completely fully digital workflow, we need more than 2 hours, 122 minutes. It's extremely fast. So chair-side mode, completely digital mode is very fast, but it's available only for clinics which have any type of milling machines, because without milling machines, we need to use only analog digital or digital workflow. In that case, we scan our case from clinic, moving to laboratory, and from that point, from that point, it will be absolutely the same like for analog digital workflow. And of course, we have some benefits with digital, absolutely digital workflow. It's the speed of transmission data to lab, as I said before. We can have chair-side possibility. We can get great motivation for patient. We can show any stage of our production. We can check patient agreement on any stage. It's very important. We can get great precision of our prosthesis. All step control. We can check scan, we can check design, we can check production, and we can step back to remaking some treatment. We can rescan, we can redesign if we need. Of course, we have minimal loss of an alteration of any project. If patient will crack his crown, we can make this crown very simple and very fast, and we can remake design without any new impressions. It's very important. And of course, we have ecosystem containing scanner, software, milling machine, and furnace. It's like Apple ecosystem. And of course, wow effect. Patient will tell everybody around him about your workflow, about your clinic, about you like doctor, and you will get more patients from that patient. It's very, very important. That's all for my presentation. I finished. My contact data are on the screen. You can write me at any time. You can ask me any question at any time, and I'm ready to answer your questions right now. Wojtek?
Yes, thank you very much, Sasha, for the great presentation, as always. I think it was so detailed that we hardly got any questions. I think, Niklas, you got a question.
Yes, Dr. Simonenko, we have a question from a lab. They have a patient with a very high gingiva or thick gingiva. And sometimes when using bonding base, the bonding base is too low if they want to work digital. What are your recommendations in this case?
Thank you. I will show you the slide again. 1 second. When we use, for example, when we use CEREC workflow, it's very important to have the titanium base with higher neck, because we can use this titanium base for scanning. And it's very unuseful to use this. Do you see a mouse pointer?
Yes.
Yeah. Okay.
Yes.
And it's very unuseful to use such type of titanium base for scanning, because gingiva can be very thick, and we can't see this titanium base after screwing. In that case, for CEREC systems, we have titanium base with higher neck, because we can use this titanium base for scanning. But for open systems, you can scan with very high scan abutment like this. And in that case, you don't need to use titanium base with higher neck, because you will design a transgingival part of the crown by yourself, and you can produce any type of this crown. I think I answered the question.
Thank you, Dr. Simonenko. Yes, I think that, yeah, sorry.
Good morning, everybody. Good morning, Sasha.
Good morning,
this is a very common question, and a lot of customers do not understand what you just said, that they create the gingiva height and the gingiva profile. I mean, this is the biggest advantage we have with this technique, and so it is very important for them to understand, since they cementing the crown on the bonding base outside of the mouth of the patient, it doesn't matter at all how high this bonding base is. And this is a I have this question so often, so we have to really push that answer very clearly.
Okay. Thank you, Dirk. Any other comments?
I have one comment, if you don't mind.
No, of course.
It's absolutely unacceptable to use such parts like titanium base for that type or that type inside the mouth, and cementing the crown inside the mouth. Absolutely inaccessible, because these parts are laboratory parts. You need to fix onto the model in your hands or in your model, not in the mouth. It's very, very important. Thank you, Dirk.
Yeah.
Thank you very much. I can't see any other questions. So in that case, we'll be coming slowly to the end of our today's event. For those who would like to have some repetition of the lecture, or would like or couldn't simply watch the whole presentation, please be informed you can still watch it on Facebook, on SIC Invent Facebook page, and on SIC Invent YouTube channel. The presentation will be available for a limited period of time. So now I would like to invite you to our next week's webinar, same time, same place. Tuesday, 11 o'clock. This time we will be talking about highly requested topic, that is SIC Invent implants integration with open CAD/CAM systems. Thank you very much for the participation. Please follow our social media to find out more about coming events. Thank you again, and see you next time. Bye.